Hello, I'm Arpita Paul. Today I'm going to talk about cardiovascular disease in Indian high-risk population. First, I'm going to talk about the cardiovascular disease in common. Cardiovascular disease are a group of disorders of the heart and blood vessels, most of which are caused by atherosclerosis, which is caused by plaque formation of fat in the inner walls of the blood vessels. And the cardiovascular disease includes some of the disease named coronary heart disease, cerebrovascular disease, peripheral arterial disease, rheumatic heart disease, congenital heart disease, deep brain thrombosis, and pulmonary embolism, and etc. In the all of the cardiovascular disease, heart attack and strokes are the most common cardiovascular disease, and heart attack is a arterial disease, and stroke is a cerebrovascular disease. So I'm gonna talk about the symptoms of heart attack. The people who have heart attack comes with the symptoms of severe chest pain in the mid chest, which radiates to the left arm or left jaw. They also present with nausea or vomiting, cold sweat, the lip blue or cyanosis. They also come present with shortness of breath and lightheadedness. And when we see the symptoms of stroke, they present with the sudden weakness or numbness in the face, arm, or leg, most often in the one side of the body. They also present with confusion, slurring of speech, difficulty seeing with one or both eyes, difficulty walking, severe headache with no cause, or fainting or unconsciousness. So there are several risk factors of cardiovascular disease. Some of them are modifiable, or some of them are like non-modifiable. The most modifiable risk factors are like behavioral risk factors, socioeconomic risk factors, occupational factors, and educational factors. And the non-modifiable risk factors are genetic factors and environmental factors. And behavioral factors which are like mostly modifiable are like physical inactivity, high fat diet, tobacco smoking, which can be which risk factors can be prevented by individual effort. There are some socioeconomic risk factors, which are poverty, location of grocery stores, affordable fast food, ethnic and cultural foods, cultural behaviors, social circle of different health choices. These are all also modifiable. And when we say the genetic factors, we are saying that family history of cardiovascular disease, hypertension, and diabetes, which are mostly non-modifiable factors, and some people are also born with the defective gene of cardiovascular disease. They are prone to cardiovascular disease. And we also got some occupational risk factors like sedentary lifestyle, which leads them to physical inactivity and make them vulnerable for cardiovascular disease. And there are some educational risk factors, the people who has less education, they also lack of health literacy, make them uh, make them behave like bad health behavior, make them more prone to cardiovascular disease. And there are some environmental factors like air pollution, temperature, or weather. Air pollution, it can be changed, but the temperature, weather, sometimes it also affects the cardiovascular health, which cannot be modified. Here I have presented some global data of cardiovascular disease. We know that it's actually the major reason of death in globally. It caused 17.9 million deaths in individuals in 2099. 85% of these deaths were attributable to heart attacks and strokes. More than three-quarters of cardiovascular deaths occur in low and middle income countries, and 38% were caused by cardiovascular disease. Within these 17 million premature deaths, of these total cardiovascular deaths, annually 8.6 million are by women, and 15% of this death and disability can be prevented by a combination of simple individual efforts or national efforts. Here I have presented a global health estimate of all deaths, and we're seeing that cardiovascular disease is the top leading cause of death, which stands for 31.4% death in the all day among the all deaths in the whole world. So here I'm gonna talk about little bit about the cardiovascular disease background in India. Cardiovascular disease is more prevalent among Indians than the Western population. According to the World Health Organization, India is responsible for one-fifth of these deaths globally. According to the Global Burden of Disease report, India has its standardized cardiovascular disease death rate of 272 per 100,000 people, in contrast of 235 in the worldwide average. According to the World Health Organization, cardiovascular disease was also responsible for 28.1% of all death in the India in 2016, and 14.11% of all disability in 1990. Here we are seeing that all of the India states are prevalent with cardiovascular disease, but the most prevalent state with cardiovascular disease are Tamil Nadu, Kerala, Andhra Pradesh, Maharashtra, Punjab, Haryana, Himachal Pradesh, and West Bengal. Here I have presented some data of cardiovascular disease statistics in India. We are seeing that many of the cardiovascular disease states, we found that ischemic heart disease and strokes are the leading cause of cardiovascular disease death in India by cause in 10,000 population. Here I have also presented some data of urban and rural prevalence of cardiovascular disease. I have shown the cardiovascular disease prevalence in many age groups. We are seeing that urban prevalence urban incidence of cardiovascular disease is more than the rural incidence of cardiovascular disease. So India has a prevention strategy, which is actually implemented by Indian Council of Medical Research called ICMR. They actually monitors the cardiovascular disease in India as a part of WHO sponsored multi-center study. As we know that WHO classifies cardiovascular disease prevention in three approach. One is individual approach, one is population-based approach, and another is patient-based approach. So with the collaboration of WHO, ICMR actually builds sentinel sites for monitoring cardiovascular risk factors throughout the country and examines implementing the WHO STEPS instrument for the surveillance in the country. And with the collaborative approach of WHO, they also monitored the sentinel location under the direction of Ministry of Health and Family Welfare to develop a national strategy and modules for national cardiovascular risk factor surveillance. Here I have targeted a population. They are urban Indian men within age group of 18 to 65 who are exposed to tobacco usage in regard of different socioeconomic status within different dietary habits. Why I have chosen them? Because we know high prevalence of tobacco usage among Indian men. They are more prone to Indian men are more prone to CBD. We have gathered many evidences from some research paper, and we also know that lower socioeconomic condition tends to low health literacy and stress, which can make people vulnerable to cardiovascular disease. So I have wanted to compare the cardiovascular disease in both low socioeconomic status and high socioeconomic status. And in urban people, we have seen more fast food consumption, And as we know, India has very um, um, India has many kind of dietary habits in the urban area. Like in many states, there are vegetarian, and in many states there are non-vegetarian diets. So we also wanted to see the difference of cardiovascular disease risk in this vegetarian and non-vegetarian dietary habits, and we also say that in urban people there is increased sedentary behavior, so it leads them to physical inactivity and make them more vulnerable to severity. So I've also explained why I'm addressing this target audience. So low, which in my target audience, there are Indian people. So why Indian people? Because in many evidence, from many evidence, we have collected data that South Asian people have narrow coronary arteries, and in the Indian people, we have found that they have more narrow coronary arteries when we compare them with the Western counterparts, because they have a small body stature, and they are found to be they are found to be more prone to cardiovascular disease, because due to the smaller arteries, they have a more left anterior descending artery and coronary artery stenosis, so they have more cardiovascular disease outcome. So, so this is making a huge burden on healthcare of the hospital healthcare sector in the urban India. And I have also shown how the health literacy in the large population of urban areas, making them more prone to risky health behavior like tobacco use, high-fat diet, non-vegetarian diet, and sedentary lifestyle, and making them more prone to cardiovascular disease outcome. And I've also wanted to see the socioeconomic status difference in the cardiovascular disease risk. So mainly, um, I wanted to target this audience because they are having more cardiovascular disease outcomes, and they are making a huge burden on the healthcare sector of urban India. And there are some potential problems which I wanted to mention, because cardiovascular disease with the cardiovascular disease, there are some other kind of disease which are prevalent, so which is making a dual burden of disease. The low health literacy level is tending the population to have cardiovascular disease risk due to lack in insurance, increasing uncontrolled high out-of-pocket expenditure for diagnostics, test and purchase of drugs. Unbridled corruption in India tends to reduce cardiovascular health promotion. Unfavorable duty structure make medical equipment import cheaper than the Indian production, and drug without active ingredients or lower amounts of active ingredients in hypertension drug or diabetes drugs result in longer treatments with no recovery, and making them more vulnerable to cardiovascular disease. There are also some challenges which I wanted to talk about. Mm, India needs to imply cost-effective treatment to tackle the cardiovascular disease burden. They also need to implement policy beyond the area of healthcare. They need to modify their tobacco policies, because we know that in many places of India, the tobacco policies are not strict, and they will also need to give more attention on the salt reduction strategy, as we know that Indian people use more salt in the cooking process, and in many places of in India, people also suffer from iodine deficiency. So they because of this cause they sometimes intake more salt. So we need to implement salt reduction strategy. This is a big challenge. And without these problems, we have also some opportunities. We know that India have a large employable population. We can use them in a cardiac healthcare workforce. We can also use them in elaborate network of healthcare centers. We can increase the domestic focus on drugs manufacture. There is a very high demand for cardiac specialty and tertiary care hospital in India, and even providing quality healthcare, cardiac healthcare service at a lower cost as a part of medical tourism. that attracts also investments. And people are being aware right now about their health, so that's why there are high demand for cardiac medical care. So the communication platform I have thought to use are cable television, newspaper, and billboard, and social media platforms and workplace health promotion. As these all of the communication will be offered in a multiple language, as we know that India is a multilingual country, and we know that all urban people have access to the cable television, newspaper, and billboard. So any news of the cardiovascular diseases can be spread to them by these platforms. And we know that people use more of their time in social media right now, so we can make YouTube videos and Facebook ads to reach the most of the age group people. And we can also implement workplace health intervention, workplace health promotion by using infographics. We can arrange healthcare in workplace and make them know about the cardiovascular disease risk, and educate them how to prevent the cardiovascular disease in my target population. And here I have also shown COVID-19 as a station of cardiovascular disease. We know that COVID-19 is largely a respiratory condition, but in many patients develop new or worsening heart problems while they are COVID affected. They also develop some cardiovascular symptoms when they are COVID affected, like acute myocardial injury, altered myocardial demand, tachycardia or bradycardia, plaque rupture, coronary thrombosis. 10.5% of these of the people who have attracted 10.5% of the 72,000 people who have contracted COVID-19 in India died as a result of cardiovascular disease after contracting the virus. So we are seeing that there is a big association of COVID-19 and cardiovascular disease. So why this COVID situation in the target? Why this cardiovascular disease situation in my target audience, making them more vulnerable to COVID-19? Because we are selecting our target audience as the urban people. We know that urban areas are more populated, so more population is making tending to the more COVID infection. And we are making and we have targeted my audience who use tobacco. So tobacco usage make their lungs more vulnerable to COVID-19, and there we have seen from many results that there is 2 to 4 fold greater risk of severe illness or admission to ICU in COVID-19 patients with cardiovascular disease and hypertension. And we have also addressed lower socioeconomic status, who tends to less health literacy, and they use and they have lesser use of masks, and they have lack of sanitation knowledge, making them more prone to COVID. And as we have seen, many kind of diet are actually prevalent in India. So poor diet provokes these people, these urban people, to cardiovascular disease, making them more vulnerable to COVID-19. As we have seen that how this COVID-19 and cardiovascular disease are related. So, for my target population, I have selected some fit intervention strategy which can be improvised in future days. Like we can induce young age test, which can be beneficial for early detection and therapy. We can use regular involvement in healthful group exercise like walking, yoga, and meditation that might help overcome severe cardiovascular disease. We can increase national spending on cardiac technology and equipment. We can encourage health insurance for an individual to decrease out-of-pocket payments. We can increase more funding in pharmaceuticals and diagnostics. So I think in my target population, as they are more prone to severe cardiovascular disease, we can we can educate them by using this intervention strategy, by social media and cable television and multimedia. So that will decrease the greater burden of cardiovascular disease in India, and will impact a less spending in the healthcare of India. So that's all from my section. Thank you so much. These are the reference I have used for my presentation.